Is that fine?
Yes, perfect.
Okay. Yeah, I was saying good afternoon or evening, everyone. Thanks to the organizers for giving me this opportunity to have this discussion around the comorbid illnesses in COVID patients. Igama lami Nangamso Kukulela. I'm one of the specialist physicians here at Netcare Sunhill. We've been at the forefront of this pandemic since the beginning of time with all the other physicians this side. And so far so good. We've had bad moments and good moments, but we're soldiering on, and we thank everyone who's been supporting us. We thank the management for allowing us and giving us a space and giving us everything we need basically to enable us to help the patients and to have good results. So tonight we're basically talking about the comorbid illnesses in the COVID patients. So just as an introduction, I'm sure we're all aware of this. So basically the disease, COVID-19, is a respiratory infection caused by severe acute respiratory syndrome, coronavirus 2. So with this kind of situation, there's always a disease and a virus, just like in HIV and AIDS. There's HIV virus causing the AIDS, which is acquired immunodeficiency syndrome. So in this case, the virus is the SARS-CoV-2, which is a severe acute respiratory syndrome, coronavirus 2, and the disease coronavirus 19. These are named differently. The virus is named because of its structure, basically its genetic material and structure. So in terms of the COVID or the coronavirus, it's named because of the shape of those spike proteins that resemble the crown, which is a corona in Greek. So it's named so in terms of virological terms, so as to facilitate discussion around diagnostic tests, vaccination, and to basically find treatment. And in terms of the disease, mainly for epidemiological reasons, to facilitate discussions around transmissibility, the spread of the virus, how to prevent it, and treatment and control measures. So this virus is basically a family of envelope positive sense single-stranded RNA viruses. Usually they tend to cause mild upper respiratory tract infections in humans. But as of late, we've seen like severe illnesses being caused by this. There's about around 7, I think, that have been identified, but there's 3 known that are known to cause severe infections in humans. Around 2 or 3, they discovered the CoV-1, or just CoV, the SARS-CoV, which was also in China, southern China, which was thought to have originated in the kivet kids. And then later on in Saudi Arabia, they also discovered the MERS, which is the Middle East Respiratory Syndrome coronavirus. I think this is still continuing, actually, still get cases of MERS, and it's thought to be originating from the dromedary camels. And of course, the big one that we're struggling with now is the SARS-CoV-2, which started in end of 2019, around November actually, and then in December it was officially declared as an outbreak. So coming to our topic, COVID-19 and comorbid illnesses, why is it so important that we discuss this and that we are aware as clinicians of these kind of situations? It's because the limited literature that we have at the moment has shown that comorbid illnesses actually result in severe outcomes when someone is infected with the coronavirus. The risk factors for severe disease that have been identified is obviously the age, to start with, age above 65, with the median age around 60. And the patient with the following pre-existing conditions, they tend to have severe outcomes, they tend to have complications, mortality rate is high. Patients with diabetes, obesity, hypertension, chronic kidney disease, not so much in chronic lung disease, but as well they tend to have severe complications and outcomes. And in particular, coronary artery disease has been shown as a risk factor for severe complications and other cardiovascular diseases. Also, immunodeficiencies, like patients with chronic steroid use, congenital immunodeficiencies, HIV, and other forms of immunodeficiencies. And also pregnancy has also been listed as one of the risk factors. This is basically due to the change in immunity around pregnancy and the coagulopathy that we're going to discuss later on. So these patients at higher risk compared to the general population without pre-existing medical conditions, at higher risk for hospitalizations, ICU admissions, and intubation. And they tend to stay longer in hospitals, such that they develop other complications. We find that now they die from other things, even though they initially came in as COVID pneumonia, moderate to severe COVID pneumonia, but they end up staying longer in hospital and developing other complications related to COVID or not related to COVID. And so yeah, the scale of severe outcomes and complications, and the mortality rate is way higher compared to other patients without these pre-existing comorbid illnesses. This is just some epidemiology studies that have been done. Mainly, the initial people to experience this were the Chinese, so they did a lot of studies. They just copied studies mainly from Europe, China, and the USA. They said these viruses usually called mild illnesses. Around 80% of infections are mild, and then around 15% cause actually quite severe infections that require medical attention. And a fewer percentage of these patients, especially those pre-existing medical conditions, they actually require critical interventions and transfer to ICU. And it's been said that the median time from presentation of symptoms to transfer to ICU is around 4 to 9 days. Between 4 to 7 days, that's a critical period, but the median range is actually 4 to about 9 days after the symptom presentation. So as you can see, this usually causes mild illnesses and resolve on its own, but quite a number of patients, they do require severe, they do present severe conditions, and about 5% of them would require transfer to ICU and ICU management. So looking at the studies that have been done so far, almost just less than a year now from the China experience. So physicians and clinicians outside and researchers, they combined 3 studies that they did to look at the risk factors and the patient with these comorbid illnesses. And they found that a patient with these, like hypertension, controlled or not controlled, with or without target organ damage, they're actually 24 to 30% higher, at higher risk of having severe outcome complications compared to someone who doesn't have hypertension. The same with diabetes. This is mainly for type 2 diabetes. There's limited data in type 1 diabetes, but the studies have been smaller, like 50 patients or 40 patients. But mainly in type 2 diabetes, actually these patients have 12 to 22% of actually developing severe outcome. As I said, coronary artery disease is quite a big issue as well. These patients actually don't do well unless managed properly in a correct place. Also cerebrovascular accidents, ischemic strokes or hemorrhagic strokes, from 2% all the way up to 22% of the population actually have severe complications from COVID. So as you can see, basically, the combined 3 studies that pre-existing medical conditions, these patients with pre-existing medical conditions, they don't do well once infected with COVID. But the actual risk of conducting infection is more or less the same for everyone. But once you have it in a pre-existing conditions, in terms of the outcomes are not so well. Also the mortality estimates from the same studies as well. So at the moment, I think the crude mortality rate is around 2.9 to 4% globally. But patients, as I said, the age, patients above the age of 80, so a lot of that in countries like Italy, Spain, and USA, they don't do well at all. And again, patients with cardiovascular diseases and patients with diabetes mellitus. So yeah, this is quite important in how we assess our patients. When they come in, we just need to get their background and be aware if they have accelerated complications or not, and then we manage them properly. So just collected a few just a few data from like different parts of the world. You can see here clinical characteristics of the coronavirus disease in China. You can see most of these patients that were admitted, this data is mainly from the patients that were admitted in hospital, hypertension and diabetes, like high numbers. Many few patients have got other comorbid illnesses, but mainly diabetes, hypertension, coronary artery disease. That was in China. And then here, this study was done actually in the USA, in Detroit. Also, more or less the same thing. These patients with pre-existing medical conditions, they have a higher risk of hospital admission compared to the other patients. And once they're admitted, the high risk of ICU admission, incubation, longer hospital stay, and severe outcomes, basically, unfavorable outcomes. So this one was in the USA. And then in Italy as well, as many studies that have been published, just selected a few. Also, more or less the same thing. We see a similar pattern. A lot of patients, hypertensive, start of almost this one, I think about 1,500 patients. So a lot of hypertensive, cardiovascular diseases, high cholesterol, diabetes, mainly type 2 diabetes. That's associated with age, of course, and all those kind of things. So you can see these patients don't do well and they're at risk of ICU admission immediately. This one was the first 24 hours, and most of these patients ended up in ICU. And of course, our colleagues down the road in Parktown, they can't be left behind. So they did a study as well in South Africa just to see the first 100 patients who were admitted at Joburg Gen, Haematological Hospital. But it's a small study, only 100 patients. And even here, sort of it gives an indication that most of these patients that were actually required admission have these kind of pre-existing medical conditions, hypertension, diabetes, and the rest. So just taking a step back to go through the pathophysiology of COVID-19, see why it's so virulent and why it's so causes such a intense inflammatory response in the body. So basically, as we all know, it's mainly spread through the respiratory tract by aerosol droplets, respiratory secretions, and the direct or indirect contact as well. So as I explained, the structure of the virus initially is what there is proteins around it, the spike proteins called S proteins, the envelope protein, and the nucleus protein, which is inside, and the E protein. So mainly it uses the S protein, which is the spike protein, to bind to its host receptor, which is actually has been identified as the AC2 angiotensin converting enzyme 2. Cells. These cells are widely distributed throughout the body. So, but they're highly in high numbers in alveolar type 2 cells. So it binds in the presence of the human enzyme transmembrane protease kinase 2. So the virus will actually use this enzyme for priming, and it's also aids in the membrane fusion. And then the virus enters the cell by endocytosis. As I said, the AC2 receptors are highly expressed in the body, in your cardiac cells, blood vessels, intestine, kidneys, and in higher numbers in your alveolar cells. So there's been a concept called the cytokine storm or cytokine release syndrome, if you want to say. So this is basically one of the mechanisms why this virus is so virulent, the intense inflammatory response that it causes in the body. And then obviously it accelerates the severe manifestations of this disease. There's different mechanisms, but this is one of them. So once the virus enters the cell, it causes internalization and downregulation and inhibition of the AC2 cells. As you know, the AC2 cells are quite cytoprotective, you might put it that way. They're highly expressed in a number of cells. They're involved in a number of processes in the body, like fluid balance, electrolyte regulation, BP control, cellular permeability, tissue growth. So this cell actually downregulates all those processes. And also induces the enzyme called ADM17 gene expression. This leads to a release of pro-inflammatory markers, including human necrosis factors, the cytokine, and interferon alpha. So this activates pro-inflammatory pathways leading to intense inflammatory response called a cytokine storm or cytokine release syndrome. So it also induces a direct injury, direct and acute injury to the cell, myocardial cells, parenchymal cells, and endothelial cells and other organs. So this is just this is just a picture basically just to demonstrate the 5 steps of how the virus enters the cell and produces more virulence in the body and replicates. So as I said, it attaches via the AC2 receptors in the presence of the transmembrane proteinase 2. So that's used for priming and aid in the fusion to the membrane. And then it penetrates, enters the cell via endosmosis. Once inside the cell, so it results in a biosynthesis, more viral replication. Messenger RNA and the nucleic acid are being used. It produces more virions, basically the virus, and then it matures, and then gets released and gets spread throughout the pneumocytes, alveolar cells, throughout the other cells in the body. As I said, also in the presence of this also induces the ADMT17 enzyme, and this results in the release of pro-inflammatory cytokines, resulting in an intense inflammatory response, basically. So that's just a nice picture to just put all this into context. So it binds AC2 receptors, gets internalized, enters the cell, the virus replicates, produces more virions, and downregulates the AC2 receptors. And this is the effects, basically acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. So basically, in the absence of the function of the AC2, this is, as we said, is involved in a lot of these processes. So that's just showing where the cell, the drug that I used, antihypertensive ACE2 inhibitors and the angiotensin receptor blockers. So as you know, the ACE enzymes, they are involved in the conversion of angiotensin 1 into 1 to 9, then angiotensin 2 into 1 to 7. So these are the processes that the ACE basically is involved in. And that process regulating fluid and electrolyte balance, tissue growth, vascular permeability, endothelial cell, and all that. But without this, the virus is downregulated, all those processes basically to acute tissue injuries. There's been discussion initially about patients that are on ACE inhibitors, angiotensin receptor blockers, if they're at higher risk of SARS-CoV-2 or not. Because if you're using these antihypertensive, you've got higher expression and representation of the ACE2 receptors. And both actually the European Society of Cardiology and the Journal of American Cardiology also they've issued statements saying that there's no risk, there's no evidence. So patients that are already on these antihypertensives, they can continue, they're not at risk of having severe diseases or anything like that. So that was cleared, I think, some time ago. So yeah, there's no issues there. So just a few points on why the SARS-CoV-2 is highly contagious. You know, this virus is highly virulent, it spread very easily, very short of time, and obviously know now it has spread globally over a very short space of time. Some of the reasons are that this virus is capable of producing high viral loads. Once it enters the cells, it replicates and produces high viral loads, and those are shared very quickly. And it's got efficient and prolonged viral shedding. So once someone's got this virus, they can actually produce the virus for up to 20 days. Even if the symptoms have resolved, they can still continue producing the virus. And a few case studies actually have shown that people can actually continue to spread or produce a virus that spread for up to 37 days. So it can outlast the resolution of symptoms. Finally, the patients are no longer symptomatic, but they're still producing and sharing the virus. Also, the other point is that asymptomatic individuals are also infectious. I know the World Health Organization at some stage did issue a statement about this, but it's been shown that asymptomatic or pre-symptomatic individuals are quite infectious as well. And we find that viral peaks even before the symptoms are present, and they produce enough virus to spread, just like someone who's symptomatic. So this is why this virus is highly contagious. People walk around asymptomatic, but they're producing the virus and they're actually shedding it around. And also it's been shown that the SARS-CoV-2, it remains infectious in surfaces outside the host for a few hours or to a few days. This basically depends on the size of the nucleic droplet and also the surface, the temperature, and the humidity levels. So yeah, this is just a few points, but it shows this virus is actually quite contagious and spreads easily, symptomatic or not symptomatic, which is why you all basically need to be careful around. Because I know many screening tests now that are based on symptoms and all those things and temperatures, but people who are pre-symptomatic, 2 or 3 days before the symptoms actually appear, it's been said they can actually produce high viral loads and actually shed it to other people. So that's just a slide to show from the Journal of Hospital Infection that this virus can actually stay outside the host infection for a couple of hours, up to 3 days in certain instances. And it shows basically a smaller droplet, it can travel up to 2 meters, and larger droplets, they tend to drop towards the ground within a meter. But it also depends. Some interesting articles say that people actually singing or yawning or yelling, actually, they can actually transmit the virus even further than this. If you're shouting at someone or shouting at people like shouting at nurses, must stop doing that, because they actually spread this virus very far. Well, now we have all the masks and all that, but yeah. So key mechanisms in multi-organ injury. As I've said, this virus is capable of causing a lot of intense systemic response in the body and a lot of multi-organ damage. A couple of mechanisms have been put forward as responsible for this. So first, a direct viral toxicity. Once it binds to the SA2 receptors, it induces an intense inflammatory response and causes acute lung injury, myocardial damages, endothelial damages. The second one, that endothelial damage actually causes a lot of inflammation. It results in increase in thrombin production and actually reduces the fibrinolysis that usually happens in the body. So it creates a sort of a DIC-like picture, and also dysregulation of the immune system. One of the cardinal features of these patients, we find that they have lymphopenia, and which has been reported in up to 90% of hospitalized patients, and which is a marker of impaired cellular immunity. As I said, dysregulation as well of the renin, angiotensin, aldosterone system. So the ACE is involved there. So basically, as you know, all the spleen fluid electrolyte balance, BP control, vascular permeability, and tissue growth. So also just as a reminder, the risk factors of age, also in an ICU is a different scores to see who's more sicker, who's going to need what, who's going to deteriorate quicker, who's going to do well. One of the scores that have been used is the SOFA score, sequential organ functional assessment. And then there's a shorter version of it, which is a quick SOFA, quick special organ assessment. Basically take into account your respiratory rate, your blood pressure, and your mental status. And patients who come with higher scores basically don't do well. And D-dimers, we're going to touch into those and get to extrapulmonary manifestation. Find that this patient, they're hypercoagulable. They have a lot of the D-dimers are high, the increase of venous thromboembolic complications, actually also arterial thromboembolic complications, and also one of the cardinal features lymphopenia, to the mark of impaired T-cell immunity. Also, just to recap, in the presence of coronary artery disease, diabetes, hypertension, the severe manifestation is accelerated, basically. This is just a nice graph just to confuse everyone. So basically, you know, the viral entry mechanism binds into the cells, the presence of the transmembrane, serenase 2, virus gets into the cell. So they said the first mechanism, a direct cytotoxic effect, And then regulation of your renin-angiotensin aldosterone system. This all results in tissue injury, remodeling, inflammation, also constriction and vascular permeability. Also endothelial damage and the trauma inflammation. There's a lot of endothelial damage in apoptosis, basically. And as I said, it creates a sort of a DIC picture. We find that there's a decrease in fibrinolysis and increased production of thrombin. So what happens in your vascular permeability, increased edema, and a lot of pro-inflammatory cytokines. That's in what you call the cytokine release syndrome. Basically, the interleukin-6 has been using it now. It's sort of a marker of a patient is having cytokine storm or not. Who's going to need what treatment, and the treatment that we use that are available basically at our disposal. Also, dysregulation of the immune response. As said, T-cell lymphopenias, impaired of interferon signaling. This results in an exaggerated innate immune state, basically, and the release of this inflammation. So there's inflammation, thrombosis, and all the complications associated with that. So I thought it would be important just to touch with the extrapulmonary manifestations of SARS-CoV-2. You know, this virus is mainly respiratory syndrome or respiratory tract infection, mild upper respiratory tract infections, or severe respiratory tract infection from pneumonias to ARDS. But it's been shown, we've seen it, we see it every day. It causes a lot of extrapulmonary manifestations or complications. So starting with the serological or hematological immune-related manifestations. So as I mentioned many times before, lymphopenia is one of the cardinal features, laboratory cardinal features of SARS-CoV-2, and also the leukocytosis, neutrophil. And then inflammatory markers as a result of that cytokine release syndrome, mainly interleukins, CRP, is very elevated, also PCT, and LDH and ferritin is also very high. What we use mainly in our settings, the interleukin-6 and the ferritin, we find these are very, very high. And then, as I said, these patients are hypercoagulable. So if one attack coagulation indices, also elevated dimers, fibrinogen, and prolonged PT and PTT, basically. Complications, arterial thrombotic complications. This patient is at risk of myocardial ischemias, ischemic strokes, acute limb ischemias, mesenteric ischemias. But mainly what we've seen is myocardial infarcts and ischemic strokes. And also they can cause venous or arterial thrombotic complications, patients with DVTs and pulmonary emboli. Also find that the arterial lines, catheters, or patients that are on ECMO, extracoronary membrane circuit, they're actually at risk of clotting actually the circuit because of this complication. So what you also can pick up if the patient is actually having this cytokine release syndrome, they usually have high-grade fevers and hypotensive and slight multi-organs failure basically. It's not only ARDS, so you find that you're hypotensive, as I said, they've got arrhythmias, they've got kidney involvement, and they also have secondary bacterial infection because of impaired cellular immunity. So they also have secondary bacterial infection and sepsis. So those are just the hematological and immune manifestations. In terms of the matters of the heart, cardiac manifestations, so the proposed mechanism basically, the SARS-CoV-2 can affect the heart directly, with direct cytotoxic injury, or otherwise it causes a severe chest infection that increases the workload in the heart, so it causes an imbalance in terms of demand versus supply. So it can cause myocardial ischemias and myocardial infarction, the type 1 and type 2. You know, there's about 5 clinical definitions of myocardial infarction. So yet, basically, the one that is described is type 1 and type 2. Type 1 is a plaque rupture and arterial occlusion. Type 2 is mainly a hypotensive situation, where the imbalance between the supply and demand, basically, oxygen supply, and the demand from the heavily contracting heart because increased workload because of the ARDS or the pneumonias. Myocarditis from a direct viral, just like any viral myocarditis, basically. This leads to arrhythmias as well, and also stress-induced cardiomyopathies, biventricular failure. Can have a left or isolated ventricular dysfunction, but mainly what we're seeing is diastolic dysfunction as well, and also cardiogenic shock. So yeah, the mechanism, inflammation, cytokine storm, and the micro or macro thrombi, direct viral invasion, supply versus demand imbalance. Another busy illustration. Basically, the virus enters viral invasion, causes inflammation, a lot of inflammation, and then from the entry point, mainly it's through the respiratory tract system, affect the heart as well directly, causing fulminant myocarditis and also myocardial damage. We'll see that as evidenced by raised troponin levels, ECG changes, echocardiographic changes as well. And especially it's worse in patients with pre-existing heart failures, just precipitated. But even if someone didn't have these complications before, they can still get it directly from the virus itself. And also the types of acute coronary syndrome that I explained about, the plug rupture, encephalitis, the type 1 and myocardial infarct, due to the damage to the vessels and rupturing the plug from acute coronary syndrome. So the main complications, acute coronary syndromes, heart failures, myocarditis, arrhythmias. Yeah, that's mainly what the cardiac guys deal with when it comes to cardiac manifestations of COVID. The renal manifestations, mainly acute kidney injuries. You see more and more of these. This can be pre-renal, a patient is hypotensive, septic, or intrarenal. You find that a direct damage, also tells damage to acute tubular cells, basically for acute tubular injury, and cause a lot of electrolyte imbalances. And what has been reported in many studies like proteinurias, hematurias, and metabolic acidosis. So in terms of the management consideration, yeah, the management is the same if the patient is COVID or not COVID, but there's like renal complications. You manage them the same, evaluate your renal function, urinary analysis, and then this patient is high risk of the hypercoagulable, as I said. So you need to consider some low dose systemic anticoagulation, depending on the renal function, of course, and you need to visualize the fluid balance. Most of these patients, they're hypotensive, so you need to at least to hydrate them very well. And then the indications for renal replacement therapy are the same. What you know already, hyperkalemias, acidosis, fluid problems, anurias. So you consider that, of course, especially in the acute setting. So they said to manage them the same as the patients that COVID. GIT and hepatobiliary manifestations. Many studies have actually shown that these patients, some patients find that they present with the GIT symptoms without respiratory symptoms. Nausea and vomiting, acute gastroenteritis, abdominal pains, anorexia, and rarely in certain instances, I haven't seen it here, but they've been reported mesenteric ischemias and GIT bleeds. I've seen a couple of GIT bleeds that are not sure where they're coming from. It might be, it might not. And you find that at times as a patient who's clinically COVID, who's very sick and meets all the criteria, but the PCR is negative like 2 or 3 times. Then you find that if you do a rectal swab, it comes back positive. So there's a high, basically this virus also there's a high expression and replication of AC2 receptors in the GIT system. And in terms of the lab, I found we've got elevated hepatic transaminases, bilirubin, and they're hypoalbuminic as well. So when you manage them, consider all those. You stop all the hepatotoxins, give them albumin, obviously give the liver-friendly treatment, manage accordingly. Pathophysiology, direct cytotoxic damage, biliary ducts, also second hyperinflation as well. Also hypoxic induced metabolic derangements, not say respiratory syndrome, they get hypoxic, and that affects many systems in the body. And also the drugs that have been used. Many drugs have been tried in this condition. Some people are trying ARVs, a lot of things. So also these patients, they develop DILIs. Also the normal drugs like augmentin or paracetamols have a lot of these complications. Get a drug-induced liver injury on top of the cough as well. Endocrine manifestations. This is very important, especially now settings where we've got a lot of diabetic patients and all that. So these patients, they present with severe manifestations of the usual diabetic complications like the hyperglycemia, ketoacidosis, euglycemic ketosis, especially patients on SGLT2 inhibitors, and obviously severe ill patients who have pre-existing diabetes or obesity. These patients are quite severely ill. I just put a few points there about more severe illnesses in obesity. Because obese people have reduced lung volume compliance. So the respiratory mechanics are different because of the body habitats, and that puts them higher risk. Can't ventilate them nicely, they can't breathe themselves nicely because a lot of things that's compressing them. Airway resistance is very high, and it's even worse if associated with diabetes, which has got its own complications. At times, someone is just obese, but they're not diabetic. It's even worse if they're both diabetic and obese. And also, obese people have altered pro-inflammatory cytokine, usually more increased than the other people. So it makes this condition more severe, basically. So, pathophysiology, mainly in diabetic patients, is impaired pancreatic beta cell function, and also apoptosis, secondary to a cytokine storm, and there's decreased insulin production. It accelerates ketosis, hyperglycemias, and also there's increased hepatic glucose production because of the anti-insulin hormones, basically the glucagon, the steroids that we use. Those antagonize all the insulin production and also increase hepatic glucose production as well. So I'm not going to go to all the systems for the sake of this presentation, but this is just a summary from the European Society of Cardiology. I said in terms of thromboembolism, deep vein thrombosis, pulmonary embolism, catheter-related thrombosis. So the heart is what we call a Takotsubo cardiomyopathy. The stress-induced cardiomyopathy, basically. Some people call it broken heart syndrome. Not your boyfriend, girlfriend, broken heart situation. Now, this is like a physiological broken heart syndrome. So myocardial injuries, myocarditis, cardiac arrhythmias is explained, cardiogenic shock, and myocardial ischemias. Also, they get a lot of acute copulmonale. You find that these patients have got a raised pulmonary artery pressure as a result of the primary lung problem that's affecting the right side of the heart. We explained the endocrine complications, hyperglycemias, ketoacidosis. And our dermatology colleagues as well, they've seen a few of these rashes developing, urticarias, erythematous rash, petechia, and we're not that exposed to this side. GIT, as I said, and the hepatic complications, the renal, proteinuria, hematuria. And there's been a lot of neurological complications. I'm sure everyone has seen it. These patients are dizzy, they're confused, they don't know what's happening, you scan them. At times you find something, at times you don't find something. And the main other features, like they lose taste, lose smell, and they develop stroke as well, ischemic stroke or hemorrhagic stroke. But a lot of patients, once they lose taste and their smell, most likely they'll have a positive COVID result. So just to go through diabetes and COVID as one of the comorbid illnesses. So I just selected this one. I know there's hypertension, coronary artery disease. The outcomes are more or less the same, basically. As I said, these patients are at risk of severe complications, hospitalization, intubation, increased mortality rate, and studies throughout the world. As patients are diabetic and hyperglycemia, there's a high risk of severe complications compared to the patients without. So what does COVID do actually in these patients? It precipitates the severe manifestations of diabetes, which is your DKAs, your hyper-osmolar hypoglycemic states, and also severe insulin resistance. Find that you've been giving insulin, the patients constantly hyperglycemic and are doubling the doses. Once the COVID resolves, these patients are at high risk of hypoglycemia. Also, there's the comorbid illnesses. I've been mentioning this so many times: age, obesity, and other comorbid illnesses. These are strong correlates of severe disease. So in terms of the approach to management, depending on your setting and if the patient is well informed about their diabetes first, everyone should be educated about their diabetes, how to manage, how to observe symptoms of hypoglycemia, hyperglycemia, fluid status, what to eat and all that. So if you're managing this patient as an outpatient and they are well educated with diabetes, and educate them in terms of the COVID as well. So the main aim is to prevent hypoglycemia, significant hyperglycemia, and prevent the development of DKA. But once they develop those, they usually don't do it, so it's better to prevent it. So many studies are mainly about mainly on type 2 diabetes. There's limited data on type 1. So maintain good nutrition, hydration, glucose monitoring at least twice a day. Patients on oral medication, they can continue their oral medication. They need to adjust their insulin doses and injectables depending on their glucose trend. So the monitoring twice a day, check basically when is it high, adjust accordingly. And patients who have persistently high glucose levels, you might need to add intermediate or long-term insulin. Temporarily or on a long-term basis, depending on how the patient progresses. But the patient needs to maintain good hydration and match output input, but they must just drink just to maintain good hydration. In terms of patients already on medication, oral medication, like the oral hypoglycemics, like the sulfonylureas, usually if the patient is not eating so well, they are nauseous, they are vomiting, usually stop this medication because they're at high risk of causing hypoglycemias. And the glucose-like peptide 1 receptor agonists as well. Usually patients have a lot of GIT symptoms and nausea, the vomiting, acute gastroenteritis. So you can hold them during that acute phase, the first or 2 weeks, and you can reinitiate later on. Also, patients on metformin are high risk of developing acidosis, lactic acidosis. So depending on their renal function and if they are well hydrated, eating well. So it's advisable to stop this medication during that acute phase, and then depending on the glucose levels and the renal function, then you reinitiate later on. The not so old kids in the block, SSG20 inhibitors, usually prefer that you hold these agents. We know they basically increase the renal excretion of glucose. That causes basically volume contraction and fluid depletion. The patient is always losing glucose, and it decreases the calories in the body as well. So the risk of fluid contraction and hypotension, calorie loss, and they're also at risk of urinary tract infections. So if patient cannot rehydrate very well and replace all the fluid loss, usually hold this medication. This is outpatient, remember, but someone who can do this at home. But if not, it's easier to do it in hospital. But if someone is eating well, hydrating well, glucose is maintained, then you can continue with these oral medications. Type 1 diabetes, those guys, they need glucose. They live, not glucose, insulin. They need insulin for survival. So basically, they say maintain nutrition, hydration, and most of them, they are on basal bolus regimens as well to maintain the basal insulin if the patient is not eating properly. Even if the patient is not eating properly, they don't stop the insulin. Continuous glucose monitoring, and also importantly for them is the ketones. Because once they are out of insulin, they are at risk of ketosis. So it can increase the insulin requirements if glucose is high and the ketones are present. But if these are persistently elevated and patient is developing features of a DKA, it's better to be admitted and treat them in hospital, and there's good results with that. Hospitalized patients. So when these patients come in, as we assess them if they've like the complications, the DKAs, hyperosmolar glycemic state, then you treat according to that. The treatment goals are generally the same. So you avoid hyperglycemias, avoid fluid depletion, electrolyte abnormalities, potassium. Potassium is very important in these patients because of the insulin that they're getting. So potassium can shift and hypokalemias and all that. Hypoglycemia avoid as well, ensure adequate nutrition. So initially when they come in, they're very sick, they're in ICU. Insulin is the preferred treatment for hypoglycemia for these patients because they find that the oral agents are not tolerated or they're contraindicated. Patient is vomiting, cannot give something orally, or patients got renal dysfunction, metformin cannot work, they have diarrhea, cannot give stuff oral. So I usually hold the oral agents. I will treat with insulin, adjust accordingly depending on the glycemic trends, on the glucose trends. In type 2, the need for insulin is usually temporary. But for type 1, as I said, they on insulin throughout. So there's also a syndrome that's been described that's precipitated by COVID-19, which is severe insulin resistance. It's been reported in a lot of severe cases of COVID. Mainly correlates with inflammatory markers. Find that is a rise in interleukin 6. In this patient, they are constantly hyperglycemic as well. Most likely cytokine induced as well. So you'll have to increase or double the dose or use twice daily dosing of the insulin just to control basically the levels of the hyperglycemia. Because as I said, you want to avoid persistent hyperglycemias. At the same time, avoid hypoglycemia. So once you give more insulin, the COVID resolves, or the inflammation or the sepsis or whatever you're treating it resolves. And then now the patient, they drop, they get hypoglycemias, and there's no one watching them in the ward, and then there's complications. So you need to watch them very carefully. So yeah, just to round off, so basically the risk of contracting the infection is more or less the same for everyone if you're not basically doing the thing that we're taught to do: isolate, keep a distance, sanitize, use a mask. Everyone will get the infection if you're not doing those things. But many people at higher risk, like healthcare workers, people in nursing homes, congested areas, and all that. But the outcomes are not the same. So it depends on your pre-existing medical condition. Someone who doesn't have a lot of, not that you're not going to get severe complications if you don't have any pre-existing medical conditions, but the chances of you getting severe illnesses are less if you don't have this condition. But if you find someone who's like no comorbid background coming in, within a week they're in a vent and they don't do well and they actually demise. And yeah, so you do find those cases. But now you're talking about fully pre-existing comorbid illnesses, a higher risk of all these things I mentioned before. The mortality rate globally is around 3.9 to 4%, but for these patients goes up to 7%, 9%. It's very high, especially for those that were not controlled prior to contracting the infection. So yeah, that's why this is so important. This patient, they don't do well. And the cause of death, mainly progressive hypoxia from the severe RTS, when that the PF ratios are quite low, patient don't ventilate so well. Try different types of regulatory mechanisms, just doesn't work. Change from this setting to this setting. We prone them, we do many things, but they just progressively get more hypoxic, more acidotic, and yeah, and then they develop a multi-organ failure. It's just not the lungs only. They develop arrhythmias, heart failures, they develop renal complications. You see that a lot. You find that on dialysis, everyone's almost gonna get it there doing dialysis. And many other systems are affected, endocrinologically, hyperglycemic. So that contributes to one of the causes of death. And then there's hypotensive shock, they can get hypotensive shock or cardiogenic shock. So that's one of the causes as well. So yeah, I said I'll make this short. So this is still a relatively new condition, even though now we're sort of over it. You want it to be over, and you still need more prospective data to guide our clinical practice, to guide our decision making, so that it can be more you can have better results basically. And what is known now about this condition is probably going to change in the next few months or years, and how we manage it or treat it is probably going to change as well. So let's all do the right thing, and let's all be smart and kind. We're almost there. So far, we're doing well. Thank you so much.
Perfect. Thanks so much, Nangamaso. That was really informative and really insightful. There are a few questions in the chat bar. I'm not sure if you can see them on your side, or you can try and work through them.
How do I view that? How do you share the? Can you show me the questions, Chris?
Oh, I can read them out to you, if that helps.
Yeah.
Okay. So
Okay, and I can't see them from my side.
if you open up Zoom, it should appear there, but I'll read it out to you. Not to worry.
Where does it appear again? Mute.
Right down at the bottom, it will see something that says chat. If you can't see it, let Chris read them to you. Then you can answer them. Chris, go ahead.
Perfect. Okay, so the first one we have from Johan, were the comorbidities known and treated before admission for COVID, or were the patients only diagnosed with these problems after admission? Are we distinguishing between controlled and uncontrolled comorbidities?
Sorry, Chris, I didn't get the initial part.
So were patients known with their comorbidities before admission for COVID, or are many of them only being diagnosed after admission with COVID?
Yeah, so many of these patients, they are known with comorbid illnesses before COVID. But now it's the matter of whether they controlled or not controlled. But the few studies that we have, there's not much difference if the patients are controlled or not controlled. Let's say hypertensive, controlled without comorbid, without target organ damage. They also have severe complications as much as someone who has not controlled with target organ damage in terms of your hypertensive heart disease and developed a stroke before. So most of these patients, they had pre-comorbid conditions before admission. But then there's a few conditions that actually diagnosed diabetic during the COVID. They didn't know that they had diabetes before. So this actually accelerated the process of them being diagnosed. So they came in with hyperglycemia and then they tested positive. We do the HbA1c, it's quite high. So it's just a precipitant. It could have been happened from any other virus or any other bacterial infection. But yeah, a few of them we diagnosed during the COVID, and then a few of them, many of them, they came pre-existing diagnoses.
Perfect, thank you. The next question, so I think there's actually two there, but if the virus is contagious, why the recommendation that medical personnel can resume work within 10 days of onset of symptoms?
Well, what we practice on the ground and what the decision makers are telling us, most of the time is quite different. So people now initially it was 14 days and then it was cut down to 10 days. And then the World Health Organization actually at some point they said asymptomatic individuals are not contagious or infectious. But from the studies that we're getting, these patients are actually quite infectious and they can spread the virus even if they're pre-symptomatic or they've resolved the symptoms or post-symptomatic, you might put it that way. So yeah, to come to answer you in terms of that decisions, I don't know why they came to that basically. But from the studies that we get, these patients, they can still transmit this virus.
Okay, thank you. I think yeah, it is a topic that has kind of caused a lot of contention, but I think that the current guidelines are appropriate with the research that's coming out.
Yeah.
Hopefully time will tell.
Because in my experience, yeah.
I'd like to agree with that. I think that, bringing staff back at 5 days is from time that they were diagnosed is also something in terms of staff resources that required, and because they wear appropriate PPE. And if you're wearing appropriate PPE, you shouldn't spread the virus to anyone if you're managing it properly. And then 7 days, in all the studies, the virus has been shown to be non-viable after 7 days. So that's really the reason why we're bringing staff back at 7 days and public back at 10 days, 10 to 14 days.
Yeah,
Okay.
yeah, surely. So obviously, if you're not sick, not symptomatic, and you're using your appropriate PPE, you shouldn't spread it. That's the whole point of the PPE. So I agree with that.
Okay, thank you. The next question I think you've actually addressed is just how we talked about the well-controlled versus uncontrolled. The next question from Johan: when we test for virus on surfaces, is this for live infective virus or PCR, which only tests for viral particles which can remain for very long without posing an infective risk?
Yeah, actually, a few studies have shown that these viruses on the surfaces, they actually remain viable for those couple of hours that I showed there. So that's why you can actually get it from touching or coming into contact with that surface. So these viruses actually viable and live from what the studies are showing us. It's not like a dead virus. It's not going to do any harm in your body once you come into contact with it. So yeah, that's why it's so highly contagious. Even if outside the human host form, you can still get a viable virus, depending on the hours, how long it's been there, and also like the humidity, the surface, and all those things. So it's live viable viruses. Viral particles.
Dr. Kukulela, hence the importance of hand washing and hand hygiene after touching surfaces and cleaning of surfaces.
Definitely,
Do you agree?
Definitely. I fully agree with that. Otherwise, we won't be doing it because you can touch surfaces and then it's a dead virus won't cause much. But you have to sanitize, you have to wash your hands whenever you're touching something.
Thanks.
Okay, then the next question is, what is the mechanism for the loss of taste and smell?
Yeah, so it's basically also the direct cytotoxic injury into the olfactory cells, also into your, it's not mainly your taste buds, but it's more central. That's what the studies are showing basically. So it's a direct cytotoxic injury and intense inflammatory response that affects a central mechanism that controls your taste and the smell. So the exact mechanism is more or less the same with like how the virus affects the other system, your lungs and all that. But as for neurological system, it's a bit different. But it's quite common when you get a loss of taste and the loss of smell as well.
Okay, thank you. The next question is, what is the mechanism for the lymphopenia and thrombocytopenia? For lymphopenia and the thrombocytopenia.
Okay, so for the lymphopenia, so the virus does affect your lymphoid organs, your spleen mainly. Also, it induces an accelerated T cell immunity basically, so that it overexerts it, it results in impaired cellular immunity. So it affects your lymphoid organs directly, and then produce more of these till you deplete them, then results in lymphopenia, basically. And obviously the thrombocytopenia, as I said, it creates sort of a de-iced picture. Even though the thrombofibrinolysis has reduced the fibrosis, but it's increased thrombin production. And also, this is secondary to sepsis, because of impaired cellular immunity, and the secondary bacterial infection, and that leads to thrombocytopenia as well. So it's accelerated immunity and altered immune response. So that's lymphopenia, leukocytosis is mainly like the secondary bacterial infection, and then the thrombocytopenia.
Perfect, thank you. The next question, it is said that drinking contaminated water with the virus does not transmit the virus in the GIT. what is the mechanism or pathogenesis of GIT involvement?
So the ACE2 receptors are widespread in the GIT tract. The affinity of the virus for the ACE2 inhibitor is quite high in the GIT tract. You might or might not get it if you drink infected water, but chances are you will get it basically. But most of the time, it's not merely drinking infected water or eating contaminated food. The mechanism is different, but it's when the virus is mainly replicated through via your own body. So replicated from your pulmonary alveolar cells and then spread throughout the body. And that's why you get these extra pulmonary manifestations. But also a direct into the GIT, you can get it, a GIT manifestation, especially with a viable variant.
Perfect, thank you. Another question was sent to me privately. Do we have an idea of what contributes to asymptomatic or subclinical infections?
I think basically that depends on the different immune responses. We all have sort of genetic variations when it comes to immune responses. Some people respond different than other people. Some people are more susceptible. They have a sort of a primed immune response and they respond more severe than the other people. I said these viruses usually cause subclinical illnesses in around 80 to 85% of population from COVID-1 or just COVID years. And then other people, a few percentage, like 15 to 20%, they're actually gonna have like severe infection. So generally, like a large number of people, they don't have this accelerated immune response. It's mainly a gene expression, and also a variety of how our ACE2 inhibitors, ACE2 receptors are expressed and how our immune system responds. So that's what I could gather basically from the literature. Basically, we respond or react differently to this infection, this virus.
Thank you. I think that seems plausible. I think one more question here. I'm just aware of the time. What hypertensive would you use in the COVID patient with hypertension?
What antihypertensive? So is someone on treatment already or not on treatment?
It doesn't say. So maybe in both scenarios?
Yeah, so if someone is not on treatment already, so the guidelines are the same basically, because someone who doesn't have COVID. So you don't change the treatment guidelines. But if someone is not on ACE2 inhibitors and angiotensin receptor blockers, it's preferable not to start them on those antihypertensives and start them, can use other antihypertensives like your calcium channel blockers or your calcium channel blockers basically. Then if obviously not controlling, obviously start with any measures like start with dietary modification, exercise, and then you start with one agent, and then you can go to your thiazide, and then you can increase from there. But if patient is already on a ACE2 inhibitors or angiotensin receptor blockers, as I said, the cardiology guys, the European Society of Cardiology and the American College of Cardiology, they said actually if those patients are already on those, you don't stop, you continue. If you need to add, depending on the BP control, you can add another agent or you can remove another agent if they are hypotensive. So if they are not, it's preferable to start on a different agent. You can start with calcium channel blockers or something else, or thiazide like diuretics or combinations. If they are already, you continue on the ACE2 inhibitors or angiotensin receptor blockers.
Perfect. Thank you so much. I am just aware of the time, so I think we're going to close it there. It's just now 7:05. Nangamaso, thank you so much for your time tonight and for sharing your knowledge with us. And I think we've all learned so much from it, and hopefully we'll have you join us again.
Thank you, Chris. Thank you for the opportunity, and thank you everyone for joining. Looking forward to the next presentation.
So just as a reminder, we won't have a session this week, Wednesday. So our next session will be next week, Monday. Mandy, I'm going to ask you again a reminder of the topic for next week. I think it's when COVID is not COVID. Is that right?
I think that's the Lucille Bloomberg and panel. When COVID is not COVID is COVID. So a few cases where we've picked up malaria instead of COVID, or COVID and malaria, or COVID and something else. So because we're all COVID at the moment, so we need to start thinking about other causes: stroke, MI, malaria, all of that. So it's going to be an interesting one. Maybe Dr. Kukulela will join us as on the panel as well. Who knows?
Yeah, I'd love that.
Yeah, that's going to be quite a good one, Chris, I think, as well.
I think so.
I'm looking forward to that one.
Thank you.
Cool.
Thanks, Chris.
Thanks, Mandy. Thank you, everybody. Have a good evening, and we'll see you next week, Monday.
Bye-bye. Nangamaso, thank you.
Thank you.